Welcome to Advanced Practice, where we brew together the latest thinking in mental health practice. For decades, anxiety treatment followed a familiar arc. Someone presents with anxiety, a benzodiazepine helps quickly, the symptoms quiet down, and then months or years later, we're dealing with tolerance, dependence, cognitive dulling, withdrawal, and a medication that's harder to stop than it was to start. That reality has forced a shift. Not because benzodiazepines never work, but because the cost of long term use is now impossible to ignore. What has emerged instead is a broad category clinicians increasingly rely on: non benzodiazepine anxiolytics. Some are old, some are off label, and some represent an entirely new wave of targeted anxiety treatment. Today, we're going to walk through that landscape. We're going to talk beyond benzos, the new era of clean anxiolytics. We will start with the cleanest option we have, move through the most commonly used off labels, and then look ahead at where anxiety pharmacology is going next. Let's begin with the gold standard of clean anxiolytics, buspirone. Buspirone is often overlooked, misunderstood, or dismissed too quickly. It does not sedate, it doesn't work overnight, and it doesn't feel dramatic. But that's exactly the point. Buspirone is a serotonin 1A partial agonist. It reduces anxiety by modulating serotonergic tone rather than suppressing the central nervous system. There is no intoxication effect, no memory impairment, no dependence, no withdrawal syndrome. When it works quietly. Buspirone is particularly effective for generalized anxiety such as worry, tension, rumination, and somatic anxiety that persists throughout the day. It is not a panic abortive. It won't stop an acute panic attack in its tracks. And if you prescribe it expecting benzodiazepine-like relief, you will not think it does not work. But when dosed appropriately and given time, it often reduces baseline anxiety in a way patients describe as feeling more normal and not drugged. Another key advantage is safety. Buspirone does not worsen cognition. It does not suppress respiration and does not carry the same alcohol interaction risks as benzos. That makes it particularly attractive for older adults, patients with substance use risk, and those who need to stay cognitively sharp. The downside is patience. Buspirone takes weeks, not hours, and requires consistent dosing. But for the right patient, it remains one of the cleanest long-term anxiolytics we have. Now let's move into off-label territory. These are the medications that were not designed for anxiety, but are widely used for it anyway. Propranolol. Propranolol treats anxiety from the outside in. It does not target fear or worry directly. It blocks beta-adrenergic receptors, reducing heart rate, tremor, sweating, and the physical sensations that often escalate anxiety. This makes propranolol particularly effective for performance anxiety and situational anxiety, especially when patients say, "Once my heart starts racing, everything spirals." It is non-sedating, non-addictive, and works best when used intermittently. But it is not universal. It won't treat chronic worry or trauma-related hypervigilance, and it requires caution in patients with asthma, bradycardia, or certain cardiac conditions. Now, hydroxyzine. Hydroxyzine is often positioned as a benzodiazepine alternative, but it is more important to be honest about what it actually does. Hydroxyzine reduces anxiety through sedation and anticholinergic effects. It can calm patients quickly, but it often does so at the cost of cognitive clarity. In young patients, that trade-off may be acceptable short-term. In older adults, it can worsen cognition, increase fall risk, and contribute to a cumulative anticholinergic burden. Hydroxyzine works best as a short-term bridge, not a long-term solution. Gabapentin occupies a more complicated space. Originally developed as an anticonvulsant, it reduces excitatory neurotransmitter release and can calm somatic anxiety, restlessness, and sleep related anxiety. Patients often describe it as taking the edge off. Gabapentin can be helpful when anxiety is tightly linked to physical tension, pain syndromes, or sleep disruption. But misuse and dependence are increasingly recognized, particularly in patients with substance use vulnerability. Sedation and cognitive slowing can also emerge at higher doses. Pregabalin is closely related but more potent and predictable. It has stronger evidence for anxiety, including approval for generalized anxiety disorder in some countries. Clinically, it often works faster than gabapentin, improving both anxiety and sleep. That efficacy comes with higher risk, though. Sedation, weight gain, edema, and misuse potential mean pregabalin should be reserved for carefully selected patients and used with clear monitoring and reassessment. It is a scheduled medication. Now let's look forward, because anxiety pharmacology is evolving. The next generation of anxiolytics aims to reduce anxiety without sedation, dependence, or cognitive impairment. Rather than suppressing the nervous system, these agents are designed to modulate anxiety circuitry itself. One of the most closely watched developments is aviander. Agents in this class are designed to target stress and fear signaling pathways more selectively, reducing hypervigilance and autonomic overactivation without intoxication or withdrawal. While still emerging, this represents a fundamental shift from calming by suppression to calming by regulation. Further, there are others in development that are in the psychedelic family: L-tryptophan cholecystokinin receptor antagonist and nicotinic acetylcholine receptor negative allosteric modulator. The future of anxiety treatment is precision, not sedation. And with that broader context, let's close with a practical prescribing framework, because knowing the options is not the same as knowing how to choose. When a patient presents with anxiety and benzodiazepines are not the preferred option, the first question is not, what medication should I use? The first question should be, what type of anxiety am I treating? If the presentation is persistent, generalized worry with tension and rumination, that's day-long anxiety without discrete episodes, bispirone should be high on the list. It is best suited for patients who need long-term stability without sedation and who can tolerate a slower onset of benefit. If anxiety is situational or performance-based, driven primarily by physical symptoms like palpitations, tremor, or sweating, propranolol often is the precise tool. It treats the body's alarm response without affecting cognition. If short-term calming is needed while another treatment is taking effect, hydroxyzine may be reasonable, but only as a temporary bridge, not a default maintenance medication. If anxiety has a strong somatic or neurologic component like restlessness, internal agitation, sleep disruption, or pain-linked anxiety, gabapentin may help, provided patient selection is careful and monitoring is intentional. If anxiety is severe, refractory, and functionally impairing despite other interventions, pregabalin can be considered with clear boundaries in regular assessment. Finally, know when to pause. If anxiety escalates despite multiple pharmacologic trials, that is not a cue to stack medications. It is a cue to reassess the diagnosis, consider trauma, medical contributors, sleep disorders, or substance effects, and recalibrate the plan. The goal is not just symptom reduction. The goal is preserved cognition, functional capacity, and long-term safety. Fast relief is tempting. Clean relief is sustainable. And the more precisely we match the anxiolytic to the anxiety phenotype, the less often benzodiazepines need to enter the picture at all. Thanks for listening. If you found this episode useful, share it with colleagues across disciplines.